Hello everyone, I'm Dr. Sonia and I'll be presenting a safety and outcome study on retropupillary iris fixated IOL or IFI implantation under topical anesthesia. I have no disclosures. As we all know, capsular and zonular insufficiencies can be encountered during secondary and primary IOL implantations, and there are a lot of techniques which are being used to implant IOL in such eyes. Studies have reported that none of them can be considered as superior to other, and IFIL is one of the promising candidates, though FDA approval is still lacking for IFIL. So we conducted this study with the aim to analyze the indication, visual outcomes, safety and complications of iris intraocular lens implanted retropupillary. It was a retrospective study where we studied the electronic medical records of the patients. We excluded eyes under 12 years of age, iris abnormalities, active inflammation, pre-existing macular and corneal pathologies, and combined anterior segment surgeries. Out of 209 eyes, 27 were excluded, and we took 182 eyes for the final analysis. The surgeries were done by a single experienced surgeon under topical with intracameral anesthesia. Freedom Iris Claw lens, which is a PMMA IOL manufactured in India, was implanted in all the eyes. The surgery video shows implantation into the retropupillary plane, the haptic being enclaved, and this surgery is being done under topical anesthesia with intracameral lignocaine. We analyzed 182 eyes. There was slight male preponderance. The mean age was 64.6 years. The follow-up was 1 year, 7 months. The main indications were complicated cataract surgery in 106 eyes, and the 76 eyes had undergone implantation for secondary IOL, which included subluxated IOL, aphakia, posterior dislocated IOL, and ACIOL with secondary glaucoma. Around 76% of the patient had BCVA of 0.2 logMAR unit or better at 1 month post of follow-up, and there was mean improvement of 0.47 logMAR unit. Average refractive error was minus 0.26 diopter sphere and minus 1.44 diopter cylinder. We saw no significant change in the intraocular pressure post-operatively. The pre-operative comorbidities which we saw were poor mydriasis, pre-existing phacodonosis, pseudoexfoliation, post-trauma status, macrospherophakia, and coloboma. Intraoperative events, the most common was onial dehiscence, which was noted in 73% of the eyes, and tunnel was sutured in 7.2% of the eyes. The secondary IOL implantation group included subluxated PCIOL, aphakia, posterior dislocated IOL, and ACIOL with secondary glaucoma. Anterior vitrectomy was performed nearly in 90% of the eyes. Rest of the eyes underwent 3-port pass-plane vitrectomy. Immediate post-operative period, we saw most common complications were corneal edema, which occurred in nearly 27% of the eyes, raised intraocular pressure, iritis, hyphema, vitreous in anterior chamber, and vitreous hemorrhage. These complications were more common in the primary IOL implantation group. In the late anterior segment complication, secondary glaucoma, chronic iritis happened in 4.4% of the eyes, followed by disenclavation, iris atrophy, corneal decompensation, and vitreous in anterior chamber. Interestingly, they were more common in the secondary IOL implantation group. 27% of the eyes had developed post-op corneal edema, which was treated with medical management, and 2 of these eyes had to undergo keratoplasty, and this incident was similar with other reported studies. We saw 15% of the eyes who developed immediate post-op iritis, and 4.5% eyes developed late onset iritis. 22% of the eyes had ovalization of the pupil. Disenclavation occurred in 3.3% of the eyes. Posterior segment complications noted were CME, epiretinal membrane, retinal detachment, retinal tear, vitreous hemorrhage, and suprachoroidal hemorrhage. The incidence of that also was more common in the secondary IOL implantation. When compared with other studies, we saw that we have reported the maximum number of eyes implanted in India with Indian manufactured intraocular lens with the longest reported follow-up of 19.8 months. Other complications were comparable to other reported studies. We saw some differences between primary and secondary IOL implantation, but they were not statistically significant. Merits of this study was it reports a large number of eyes, and it emphasizes the fact that it can be done under topical with intracameral anesthesia. We did not take any comparative group. It was a retrospective study, making it a limitation, and we could not study the endothelial density because of lack of data. To conclude, our study reports the largest number of Indian eyes implanted with IOL till date. It is effective and safe option to implant IOLs. It is suitable for patients with poor pupil dilatation. It can be successfully performed during the initial cataract surgery. The complication rates being similar between primary and secondary IOL implantation makes it a reliable option for long-term vision restoration. These are my references. Thank you.
So just one question. So this is a retropupillary fixation.
Yes.
So do you do in your center over the iris fixation as well? The iris drop?
Not for the last 10 years.
Right. So I mean, it is definitely a better procedure than.
It is anatomically a better plane to put a IOL.
So cornea is probably more protected.
Yes.
Maybe a comparative data probably.
With the anti-fixation.
Yeah, could be very helpful. Thank you so much.